Impact on laboratory test results. Dr. Sita Lakshmi is a professor of pathology at St. John's Medical College, Bengaluru. She's a lead assessor and carried out lots of assessments. So let's listen to what she has to say.
Good morning to all. My sincere thanks to Professor Dr. C.V. Anand and Dr. Venkatesh for having me here today with all of you and allowing me to share some of my thoughts and experiences. Yes, we do know that pre-examination processes occupy a very, very important role in the laboratory practice. And even if I have to read what is written in the ISO 15189 standard, it would take me more than 12 to 15 minutes. So I will try and do justice to this topic to the extent possible. In the context of laboratory science, we do understand that it's very complex. There are multiple departments, multiple tests being offered, and each of these tests have different specimen requirements. So that being the case, the lab is not on its own little world. It has an important role in patient care in terms of offering the right diagnosis, which will guide the clinician towards proper therapy and therefore better patient outcome. So keeping that in mind, actually when I was looking up at different publications in the literature, I came across a very, very interesting article which spoke about the history of pre-analytical variable. Now this article, the author shares some of his own experiences. When he was a resident, he joined under a senior consultant pathologist. He was given a job description as to highlight the importance of having introduced a new test in their laboratory, clarify to the clinicians the various doubts in connection with that new test. So he went around periodically talking to various clinicians about the performance of the test, and to his bad luck, most of the clinicians expressed unhappiness about the laboratory result. This is in context of this topic, which is an unexpected high urine amylase activity. Now, the laboratory had good internal quality control and EQUAS practices in place. Everything seemed to be fine, but the clinician said these don't match with the clinical data, these don't match with the clinical presentation, and therefore there is something going wrong. So he went on to investigate what could have gone wrong. And he came across a very interesting observation. This is many, many years ago. It seems the urine samples from the patients from different wards were transported, and those days the samples did not have a lid. The nurses would carry the tray with these samples, and you know the way the nurses function in a hospital. 2-3 nurses get together, and during transport they start chatting with each other. They have the tray and the sample is there. So it so happens that these small saliva droplets get into the urine sample. And that is what accounted for the high so-called urinary amylase. But this did not match. Naturally, it did not match the clinical details, and then he realized that where the fault is. Similarly, there was another instance that he quotes when the laboratory introduced a new collection container for specimens, and they realized that randomly they were getting a lot of samples which were hemolyzed. And then they traced it down to samples originating from one particular ward. And then they also figured out that this ward is located fairly distantly from the laboratory, and the staff had to actually walk that particular distance in an open area. And this used to occur in episodes, especially during the winters where there's moisture in the air, and again open samples, droplets, water droplets used to get into the small tiny water droplets used to get into the sample, accounting for the hemolysis. So he quotes many instances like this in this article, and that's where actually it originated, the concept of pre-analytical variables. Till such time, such a concept didn't exist. Every laboratory thought if they looked after their test performance, the equipments, the internal QC and EQUAS, they were satisfied. There was nothing called pre-analytical variables. It's only after this came into vogue, and they described, in that article, they described what is called an influence and interfering factors. The influencing factors are those which are inherent to an individual, like age, gender, biological reference range, and so on. Whereas the interfering factors are maybe the drugs that the patient is taking. So they classified, and today it's actually called, I will come across, come into that a little later. So this is what they talk about, influence factor and interfering factors. And then much later came the CLSI guidelines in the year 1981, when there was a separate section for pre-analytical area of the laboratory. And then this gradually evolved and became termed as pre-examination processes, and that is what is referred to in the present standard ISO 15189-2012 that we are referring to. So we all are well aware of the very three important phases of testing, so I'm not going to elaborate on them. But I would like to draw your attention to two other. We know that there is a concept of pre-analytical testing. There's something called, pre-analytical phase and post-analytical phase. So what is this all about? Now this pre-analytical phase starts with the clinician actually thinking of a particular test, reasoning it out in the given clinical context and ordering for a particular test. So what is post-examination phase? And this is where once the result is issued by the laboratory, the way it's interpreted and the reaction and the outcome of that interpretation is the post-examination. So there are two other phases which also contribute to the laboratory performance, which we need to keep in mind. Yeah. So I would like to, at this point of time, bring out this term, the laboratory error. So when we say there is a laboratory error, it does not confine to just the analytical phase. It starts with this pre-examination and ends with the way that result is interpreted. So anything going wrong in this entire cycle is a laboratory error. So you can see that there could be umpteen number of errors that could be listed in this. I'm not going to read through all of them. Having been working in laboratories, I'm sure that all of us are very familiar with what are the possible errors that we could come across and what are the implications of these errors. Ultimately, it's going to affect a patient's outcome. And we do realize that sometimes no result is better than a bad result. So this is something that we have to keep in mind, not sometimes, always. So I came across a situation recently. What I want to impress upon is that even doctors' orders can be confusing or misinterpreted at times. Last week, I came across a patient who came to our hospital. He had a request with him for factor V assay. He's been specifically referred. They said, go to St. John's Hospital and get this test done. But poor patient, he didn't probably know where to go. He went to some other laboratory and he got a test report. He had a report. He showed me that report, and that was factor V laden. He spent 5,000 rupees for that test and he didn't still have the diagnosis. So that means to say, the laboratories which have accreditation, which have full the practices in place, have not even bothered to find out what is the history in that given case. Why was that test requested for? What does that request say? But a test has been done, which is so expensive, and the patient is so disappointed. He does not have the result that he actually has to have. So this is something that we all need to keep in mind. So I would like to start with sample first, because that's where we start in terms of testing and reporting. So we all know very well, in today's world, most of the errors are pre-analytical. 60 to 70% of them have been reported to be pre-analytical. So lot of emphasis in this. And in this process, there are several steps. Starts with preparation before collecting the sample, the actual sample collecting and handling, sample transport, and also processing prior to testing. So in this entire process, we need to put in certain safety procedures in place, certain precautions in place, instructions to be given to the patients as to how to collect the sample, what kind of containers to use, what instructions to give the patient before, how to handle the sample, and so on. So there are challenges, you all will agree. Why are there challenges in this area? Because there are many people involved. It starts with the physician, nurses are involved, healthcare workers are involved who transport samples, laboratory personnel are involved, and it becomes more challenging in a teaching hospital because the processes are quite different, and therefore these variables which are ultimately going to contribute to result interpretation are definitely challenging. Again, I just want to impress upon you that most of the errors that come easily to our light is the analytical errors. If you look at this diagram, you will clearly understand that the pre-analytical errors, actually many of them don't really see the light of the day. That means we don't even know that they exist. If I recall what Madam Dr. Usha Anand spoke yesterday on risk assessment, she gave us a scoring pattern and she told us there are certain areas, certain risks which cannot be deducted at all. And that is what is very, very worrisome. And she gave a score of, anyone can recollect how much score she gave? She gave a score of 10 for that. So that means it's high risk. So if you see this depiction, pre-analytical phase, which is very difficult to deduct, will get a very high score, and that's why they're challenging, and that's why we are here sharing our thoughts and experiences. So I told you in the beginning of this session about influencing and interfering factors. There's another terminology that is a controllable and uncontrollable variables. The controllable variables are the interfering variables, whereas certain inherent variables like age, gender, so essentially it's the same. So when I looked at a publication with all the possible risks of pre-analytical factors which could impact results, I found it a bit reassuring because certain types of errors I thought was very unique to my own institution. There would be sometimes a sample is lost, an empty vacutainer was received, and I used to be very perplexed. But when I saw this, I said, oh, not bad. It does occur in other places also. But then we need to keep ourselves very alert and open to identify these errors. So in this process, there are several factors with regard to sample collection become important. The right volume, the correct anticoagulant, the correct order of draw, detection of presence of hemolysis, icterus, and so on. And because there are so many steps in this process, naturally the errors become multiplied. So our aim is to reduce these pre-analytical errors, and if so, how do we do it? So it starts with patient identification. We do have proper procedures. The standards require that at least 2 modes of patient identification to be implemented. Most of us would go in by hospital number as well as the name of the patient, and this has to correlate with the request form that the patient has, and then only collecting the sample appropriately. So each hospital has built in its own processes to ensure correct patient identification. Patient preparation is the next aspect. Fasting, so what instructions do we give? Does he really fast for 10 to 12 hours? Because I know there's a practice in our hospital. The patients are woken up as early as 3 o'clock to start collecting fasting samples. But do we give them instructions that you should have eaten at least 10 to 12 hours before this 3 o'clock? I'm sure not. So most patients would have eaten at 10 or 11, and by 3 o'clock, the so-called fasting sample gets collected. So does it truly represent the fasting state is a big question that we need to ask ourselves when we report results. So coming to the actual sampling, look at the site of collection, the preparation of that site, and the actual collection. We should also remember that various factors like patient's posture, the collection site, the timing of collection would all contribute to the result interpretation. The technique of phlebotomy, I'm not going into details of each of them because they're time consuming. Use of appropriate evacuated tubes. Venous access is very important. So collection factors contribute significantly to pre-analytical variables. Order of draw is something that I mentioned. The size of the needle could contribute to hemolysis. If you use a very fine needle, and importantly, there are times the technician, the phlebotomist, not realizing the fact, would push in the blood through this narrow needle into the tube, which could result definitely in hemolysis. Effect of tourniquet being tied for too long, too tight, more than a minute, can have serious consequences. There are effect of fist clinching is something that we all know about. Presence of air bubbles should be detected and eliminated before the sample is processed. We know air bubble has a lot of serious consequences on the sample if it is retained. Mixing of the sample appropriately. Looking for clot. You look at the results here. What are the serious effects that air bubbles can have on a result interpretation? Adequate sample volume. Too much of a sample or too little of a sample can interfere with the result. Hemolysis can have serious consequences because the balance between what is present inside the red blood cell and in the plasma is seriously disturbed. Capillary collections. There are specific instructions for capillary collection. It should be noted that the area has to be warmed. There has to be enough circulation. The prick has to be done gently without much of squeeze. So also collecting from an arterial blood collection has a proper SOP which one should follow. So after having collected the transport related issues, when we talk about transport, 2-3 things come to our mind. One is the temperature, the humidity, exposure to light, all this come into our mind. So we have to be careful about sample transport. In this context, even slight agitation can disturb the sample to a certain extent, and therefore hospitals which use chute system, there are certain samples one has to take adequate care before actually using the chute system. Here again, quality control comes into picture to demonstrate that there is no sample deterioration and sample integrity is well maintained. This is all the more worrisome when we transport samples from one center to another, which can take a few hours. And therefore, appropriate guidelines for sample transport has to be in place. Written instructions has to be in place for sample transport, because errors can result because of improperly transported samples. And we all know that there are packaging instructions, the way samples have to be sealed, the inner and the outer sealing, important to ensure that the samples don't spill, biohazard label to be put in place. Different kinds of samples have to be segregated appropriately in order that there is no spill and contamination. All this has to be taken care of. Process related causes for pre-analytical errors are several. Here again, centrifugation, the timing, temperature and storage before testing, all this can seriously affect the test result. Time, I said, is critical when we talk especially about coagulation tests. Certain assays, the sample can be kept even for 24 hours in the room temperature, but not in a frozen or in refrigerated condition. For example, the prothrombin time. But if at the same time I perform a sample of prothrombin time on a sample which is in the refrigerator, we understand that cold activates factor 7, and therefore we could have a falsely shortened prothrombin time. So these are small things, but they can seriously impact the test result. And prothrombin time is usually done in patients who are on oral anticoagulants to monitor the effect of the drug, to prevent too much clotting, at the same time to ensure that they don't bleed. So the role of prothrombin time in these cases is very critical, and therefore it's very important that we report correctly so that the clinician bases his decision to titrate the dose of the drug based on the result that we give, and therefore we play a very important role in this situation. So I spoke about centrifugation and aliquoting samples before testing. Proper decanting of plasma will also contribute to the test result. So at this point of time, I want to impress upon you the role of an important pre-analytical variable using a case scenario. So this child is a 4-year-old who was brought to us with a cyanotic congenital heart disease. And there was no history of bleeding in him nor in the family members. He was asked, because he was going in for a cardiac procedure, basic platelet count, prothrombin time was asked for. These are his baseline tests. I would like to draw your attention to the fact that some of the test results are abnormal, and therefore, in this case, the prothrombin time and APTT were prolonged. And we realized that it's spurious only because his hemoglobin and red cell count was very high. So we need to take a correction factor for high hematocrit, adjust the volume of anticoagulant required, and repeat the test only to ensure that the test results are normal. So instead of falsely interpreting the abnormal prothrombin time, and which would lead to unnecessary unwanted investigation, just a simple step of correcting the anticoagulant volume solves the problem. So that is the importance of recognizing this pre-analytical variable, in this case a high hematocrit. So there are formulas used to calculate that anticoagulant volume, which is there in all books. Now, I just want to highlight, yes, these are also other things that can happen. A clot being removed from the sample before it reaches the laboratory, which is something interns collect the sample in one particular anticoagulant, realize that you need another anticoagulant, and conveniently transfer the sample from EDTA to a citrate tube and send it. These are things which we've all encountered. But yes, these are things which we have to keep in mind to ensure that we give correct results. So instructions for specimen collection, handling, transport, and processing need to be documented in the primary sample collection manual and strictly enforced. So the standards have listed out all these instructions, and one should carefully follow them. So there are umpteen number of pre-analytical errors, and we do realize, based on these examples that I highlighted, pre-examination process is the weakest point in the quality management system, and we need to take a lot of effort to address them. So there are several of them that I brought out. CLSI guidelines are in place, and the ISO 15189-2012 clause 5.4 has distinctly, clearly illuminated all these possible factors that we need to put in place to ensure that we prevent these errors. Definitely education, training, competence assessment play an absolutely important role. Training and retraining is something that we need to keep doing all the time. Yes, are there quality indicators in other areas of testing? For example, analytical. There are easy quality indicators, are easy to identify and put in place. Yes, of course, in pre-analytical area also, we could have a big list of quality indicators, right from patient identification, sample collection, pre-examination handling. So you could identify these as quality indicators. So I just want to end with this note. If we look at this moon as a total quality, and if we look at the finger pointing as just the analytical aspect of this quality, that's not all. We have to look beyond that pointed finger to aim at reducing all these errors in order to ensure that we give the right result to our right patient. Thank you so much.
Thank you. Thank you, Dr. Sita Lakshmi, for your nice presentation. Now, chairpersons, would you like to say something about?
First of all, I would like to thank Professor Sita Lakshmi for excellent presentation. And I am impressed with the saying no result is better than bad result. That's, I think I would like to request all of the doctors to for this.
Thank you, sir. We can allow a couple of questions. I request Dr. Sita Lakshmi to please receive the certificate and the memento. Chair. Thank you, ma'am. Thank you, sir.